Hi everyone, and welcome to this webinar on soft tissue management for the performing artist. So thank you so much for joining us this evening. I'm Katie and I'm the Training and Education Manager here at PhysiQuip. So for those who don't know, PhysiQuip provides evidence-based medical technology and training that can improve outcomes for both patients and clinicians. So we're going to start the webinar this evening with a presentation from our speaker, Andrea Lasner, followed by a question and answer session. So Andrea joins us from the United States and is a clinical specialist from the Johns Hopkins Hospital and Johns Hopkins Outpatient Rehabilitation Clinic for Performing Artists. So Andrea has been co-author on several dance medicine research studies and is a committee member chair for the American Physical Therapy Association Performing Arts Specialist Interest Group. So with that introduction, I'm going to hand over to Andrea to start the presentation.
Great, thank you, Katie. I'm very appreciative for being asked to talk on a patient population that is very dear to my heart. So today, like Katie was saying, we're going to be talking about soft tissue management for the performing artist. I not only treat performing artists as a physical therapist or a physio, but I also was a former professional ballet dancer. So that's where I've really merged kind of my two loves of science and for dance and performing artists combined, and to take care of this really unique patient population and really kind of diving into the ins and outs of this population today. So we'll talk about just kind of common soft tissue injuries that happen in performing artists. And today we're really going to be focusing on dancers and musicians. There's a whole umbrella of patients that fall underneath performing artists, but for today's sake on our time, we're going to just talk about musicians and dancers. Explain the rehabilitation considerations of the performing artist, and then dive in just very briefly on the physiological mechanisms of treating soft tissue and really kind of honing in on the technologies to enhance our techniques that we already do manually with our hands. And then just talk about, appropriate applications of when to use certain technologies and techniques with this patient population on certain diagnoses. A little background on performing arts medicine, right? So performing artists have many musculoskeletal problems caused because of repetitive, intense, and extreme training demands. They're right up there with a lot of other sports and athletes. So really these days we call the performing artist an artist athlete, of really kind of putting the parallel of the arts and what the athletic population has been doing for several years to kind of bring them up to level because of those demands. They encounter high physical and psychological demands during their life, and especially if they are at that elite level professionally. Intrinsic and extrinsic factors do commonly cause injury, a lot of times due to overtraining and overuse. So that's what our focus will be on today as well. And the varying demands really exist among different genres of dance and music. So string players versus more keyboard specific musician genres, compared to ballet dancers versus modern versus hip hop. And performing arts have stigmas about injury due to cultures and traditions. So it's very commonly talked or not talked about of having an injury and kind of dealing with it and not speaking up. But we're really changing that performing arts medicine culture of say something, take care of injury sooner than later. Performance-related musculoskeletal disorders, and just kind of outlining the some intrinsic, but also the common extrinsic factors here. You can kind of see the difference, but there's also some similarities between instrumentalist musicians and dancers of, does depend on gender, the types of injuries in dancers versus commonly females do report injury a little bit more often, and that's seen in the general patient population as well. But, female musicians tend to have an increased injury risk. But then even looking down to performance anxiety and how that plays in with the musician, and then dance surface, costumes, right? Choreography demands, and of course, notably nutrition. That's just as important as fueling the bodies, because these performing artists, a lot of time, their body is their instrument, or they need their body to play their instrument. When treating a patient, it's really kind of looking at the patient fully. And this is if it's a performing arts patient population or if it's a general orthopedic related issue, of really taking into consideration of what maybe they're presenting with, their impairments, but taking into consideration of their sociological, you know, what's happening in their social life and the psychological aspect, as well as, you know, what is their body made up of. And that's where hypermobility can play in a role in this. And, you know, they're an adolescent or they're traveling a lot, crazy late nights, or they're, you know, from city to city, and that's kind of a stress. So all three of these things do play a role in managing the patient, because we know that all these different factors are very relatable to what's happening and manifesting physically, but also is there something else underlying that we need to be addressing in addition to the musculoskeletal piece. So common clinical problems, you can see it really is an array, and we are very fortunate at the Peabody Institute, which is part of Johns Hopkins University, to have a clinic set right on campus that's part of the conservatory for the musicians, the vocalists, and the dancers to be able to access. So commonly, you can see on the right, we have a plethora of different diagnoses that we could be treating. And really, it's very parallel to the left. But as you'll see, you know, very rarely, or sometimes there can be an issue with focal dystonia, which is just more affecting, you know, neurologically, usually the hands for most musicians. And then for, you know, even having some hearing loss, that's usually primarily in the musicians, not to say that it isn't a case with dancers because of the stage or depending on how loud the music is. But really for today's sake, we're gonna really kind of hone in on repetitive motion overuse and acute trauma, because that's really where talking about a backstage situation, or whether you're getting them in clinic, or maybe it's a chronic that they've been dealing with this pain for 2 years and now they're deciding to actually just get treatment. We're really just going to focus on those top two kind of categories. Right, so when talking about all these different genres, and you can see in each of these pictures that each individual is using their body differently. And really, how do the soft tissues support artistic expression, right? How much ligament laxity is the hip hop dancer able to do an arm freeze, as you see in the top left, or how much control from the male dancer to support his female partner with lifting of that person in the air. And then you have more of the artistic expression, but of course still a lot of body movement and forceful movement from the conductor versus the orchestra or the symphony that they are making play through their motions. So it's really, there's a lot of soft tissue that's being driven on to complete these occupations. So looking at performing arts rehab, right? When a patient comes to us, a lot of the time it's because they're in pain. There is a whole screening component where we're trying to screen dancers and screen musicians to see if they're predisposed for any injury. But a lot of times we're not really getting those patients unless something has acutely traumatically happened. You know, they fell on stage, they collided with a prop, or something that they've been dealing with. And a lot of 80% of the time it's something chronic that, you know, I've had this shoulder pain for 2 years and I just can't play for more than 20 minutes. So really listening to the patient's complaint, right? That's always going to give us a little bit of insight and history on the patient. Subjective and objective measurements, right? Doing all of our basic range of motion, muscle strength testing, palpation, just as how you would normally do an orthopedic exam. The important piece is for the dancer and the music is to actually do a movement assessment. And this is where it's a whole other conversation in itself of kind of what are certain tests and measures to really have and be able to support the dancer and musician to know that they're functionally getting to what they need to do, but asking them to demonstrate what can they not do, especially if you're not familiar with a dancer or musician, you know, or can you hold your violin, or can you take a video of yourself and bring it to me so we can assess your posture. So it's really having those key things, which actually links back to the patient themselves, and they feel valued and they feel like it's an important piece of their rehab, that you're understanding and can be empathetic with them. After all of that, then most of the time, it is a lot of soft tissue management because of that overuse, repetitive movement that they are always doing, right? And the stress that's happening to the muscles, to the ligaments, to the connective tissue. You know, dancers can land up to 12 times their body weight. They're doing about, 200 jumps in an hour-and-a-half dance class, much more than what, a lot of kind of adolescent jump training programs are doing to combat knee pain. So it's really looking at what is happening to the tissues, what is compensating, what needs attention. And that's really where we're going to focus today, why it's highlighted in yellow. But not only is the manual piece important, it's then once you have either helped decrease any tension, any swelling, anything that needs that manual attention, is following it up with movement motor control, right? We want to make sure that they're able to then work in that new range of motion, recruit that proper muscle that they should be. So that is really what is going to help with the carryover from treatment to treatment with the manual piece here, and ultimately getting them back to practicing, training, and performing. Right, so speaking of soft tissue structures, right? So looking at and just reminding ourselves about soft tissue structures, we're looking mainly at muscle, ligaments, tendons, and the fascia. And it's really important to take note of the fascia component because it's continuous and it just travels from the dermis of the skin all the way down to the bone, right? It's very complex, spider webbing throughout from the cranium all the way down to the toes. And it's a continuous tensional network throughout the human body, connecting every single organ, every muscle, and even every nerve of every little muscle fiber. So it's really important to not only know that the fascia is an integrated component because of that shock absorber, especially for that dance population, but even to help support with hypermobility joints, and to also just, that's the system that takes over if the muscle is not. Complex systems, really, the complex strands of collagen, different collagen that makes up each one of those different organisms. And it serves specific roles to provide the stability and movement for function and artistic activity. So it's what gives us the ability to walk, jump, land, play, and all of the other motions that we do in everyday life. Management of injuries to the soft tissue. So it is important to kind of remind ourselves on the spectrum of where they might be coming to us during rehabilitation, of, how soon the injury was, or how long the pain has been going on, or how recent the surgery was. So really looking at the phases, right? And the main three phases of soft tissue healing are inflammatory, proliferative, and remodeling. And as you can see on the below, you can see anywhere from 0 to 25 days. How soon we get someone in, right? It is always nice to get someone in sooner than later, so they're not kind of in that compensatory mechanism, or they're helping healing and not delaying their healing. But you can see a variety of just different microorganisms here that are really being asked and called upon to help with the healing process, right? And so the one to take note here are the fibroblasts, right? Because we're going to talk about that, especially with very fibrotic tissue trigger points, things like that, because that's really where they become dormant. And the macrophages is really where we need to kind of flush those out so that they're not keeping swelling, inflammation around the area, and that we're getting the good fluid in. All of our connective tissue is surrounded by ground substance, right, which helps really moisturize our muscles and the fascia and around the ligaments and tendons, so everything slides and glides very freely and easily. So it's really important to kind of take note of where they are on this spectrum, and maybe they've been in this proliferative phase or the remodeling phase, but they just can't get back to doing what they need to do because something kind of is still being irritated and we almost need to jump start it, I like to say with a patient, especially, for example, tendinopathy. So we can choose our interventions, manually based, or even therapeutic exercise or motor control exercises to help really progress the process and where they are on the spectrum. So the mechanisms of action, and that's where there's no really one set of mechanism of action. That is the main effect of what is happening at the tissue. There might be several or all four of these main things that happen together, but really these are the four actions that are happening in the body when we stimulate the connective tissue or ask muscles to activate or ligaments to stretch, right? With that being said, right, we can get a lot of these proposed mechanisms of action, which is our daily things of, right, like fluid dynamics. We could do manual lymph drainage or use manual techniques that way. Breaking of crosslinks, you can dig thumbs into patients, right, and trying to really do cross-friction massage or work on scar adhesion. Mechanotransduction, you can get mechanotransduction to be stimulated even through exercise. And then the neurophysiological effect is really more of the gate theory, where you're trying to kind of roadblock that pain mechanism there. So in all of these different actions, we can actually help attack the system, if you want to say, or help propel the system with, we're going to talk about hawk grips, which are an instrument-assisted soft tissue mobilization technique. The LymphaTouch, which is more of a negative pressure technique, and the piezo wave 2. And each of these technologies are just ways to accentuate and enhance our techniques. And so that's where we're going to kind of go along the way with our presentation today. So with that being said, so we're going to talk about IASTM first. And this is commonly done with a sort of a tool. It's very, as we'll see, it looks very kind of sharp, and like patients don't want to be used with it, but we'll talk about how patients respond to it. They actually respond very well, but really I go for this tool, and there are many different reasons why to go for these tools, is really for muscle deactivation. That's what it's very commonly used for, is to decrease hypertonicity or break up trigger points. Aspects of tissue that is impeding movement or recruitment. Fibroblast proliferation. So we were talking about, we need fibroblasts to lay down within the collagen to take that collagen type 3 jumbled scar tissuing and realign it into nice type 1 collagen. And that's really where we want that fibroblast to lay down in that tissue so that it doesn't kind of crimp up and tighten in those trigger point related ways. Breaking up of the fiber crosslinks, as I said, and improve fluid circulation. Okay, right, so even though there might be tightness, there's a lack of circulation there. There's a lack of fluid there. Everything becomes very dry. So by creating a sort of irritation to the muscle, you're trying to kind of iron out all of that tension, you're going to increase blood flow. You're going to get the actual cellular level to bring more of that ground substance in, right? Because we want everything to slide and glide in there. And overall, it's going to then help with the patient's pain, right? We're going to focus on that one. We'll come back to the other two as we go. Right, so IASTM, right, the ability to provide a force to a broad area of focus. So commonly we can use our hands, right, and really use our thumbs to kind of dig into smaller surface areas. But with these tools, especially, that you can get a lot more done with a lot less time. And that is really the efficiency piece of things, where you can actually dig a little bit deeper, explaining that to the patient, like I can actually get into the muscle itself a little bit better. It's more precise. So the the fun piece of this is that not only you can feel vibrations in the tool where there's restriction, but the patient can as well, right? So really efficiency of the force transmission is really going a lot longer. And right, it's not to replace your hands. It's only there to supplement and enhance. There are a variety of different tools on the market. My preference is hawk grips, and there's a bunch of different shapes and sizes. So you have convex, you have concave, and so it just depends on the body region on why you're gonna go to certain tools more than the other, right? So sometimes I'll start with a concave first and then move to a convex depending on the body region. So indications really on the left are, you can use it on several indications here. And on the right, that's a full set of hawk grips. So you might only want to use one or two, but there are, as you can see, more multi-curved ones on the right, or you have very specific ones as the one on the lower left, where you can kind of get very specific, even smaller than what your thumb could get to, and even more comfortable to the patient, to be honest. Precautions and contraindications, right? Like anything, if you want to put your hands there, you're not going to put a tool there. That's kind of the end all when you think about a contraindication. Of course, patient refusal. So I always educate my patients before I use a piece of technology on them to make sure they're okay versus going straight in and just using it against their will. So of course, if they say no, then you're not going to use it. But really the big things here are not over open wounds, infection, right? Any kind of clotting or DVTs, things like that to be aware of. And then on your left, you have your precautions. So here is an example of me treating actually a stancer patient who is having shoulder pain. And this was from a car accident. So I'm just going to, you'll see me use more of a concave tool, just working to the posterior shoulder. And very comfortable, right? So I never not put my hands on a patient. I use a little bit of emollient and then dragging the tool across. And I go in both directions because you're gonna get different pickups of that tissue, either direction, right? And so you can see a little bit of redness, and that's where, you know, the tissue's a little bit tighter along that scapula. And then just getting a little bit more into that deltoid. And then I can get really specific using that smaller tool kind of all along. And I do, as you can see, I always use my other hand in some way so that the patient, especially if they're used to me doing just, you know, joint mobilizations, things like that. This is another feel-good one too. The very common suboccipital release. So not only are you just doing soft tissue, but you can actually help with mobilization. And it is very comfortable. The edges are beveled, they're smooth, and then kind of using the same technique of a suboccipital release. So I'm saving my fingers, and that's usually kind of what decreases our life as a physio is some osteoarthritis. So that's where these tools have really helped me not only accentuate my treatments with my patients, but also have saved my hands when I treat, you know, 7 to 8 patients a day at times. So they are nice and great in that way. Next, moving on to decongestive negative pressure. So this is really about fluid control, right? If someone has an ankle sprain or they might have some lymphatic decongestion or congestion, excuse me, you know, more edema. And so that's where, when we talk about the LymphaTouch coming up, it was really created for lymphedema for manual lymph drainage, but we have seen such a great change with post-operative care of getting swelling to be controlled so much faster and so much, you know, easier upon our hands with a very, very amazing, this is probably one of my favorites too, of just mechanical negative pressure. It's very precise and easy to use. And you can get a lot of superficial soft tissue mobilization at the fascial level, and that's how I commonly use it with the performing artist for overuse injuries. Right, so as you can see, basically a vacuum and negative pressure lifts up the tissue, and right, our lymphatic system sits right underneath the skin level, and that's really what changes the lymphatic nodules to open so that, you know, endothelial holes expand, and then that waste removes out, and then better fluid comes back in, right? And so if a patient has just a normal lymphatic system, right, clearing out swelling will be rather easy versus someone else that has maybe a sluggish system or has had other diagnoses that way. All right, with this, precautions, right? Skin integrity is really the main thing here. So you can decrease the amount of pressure on it, of use, if someone's very fragile or sensitive to the skin, right? So that's really where with radiated or fragile skin, that's someone if they're going through chemo or radiation, right? And so this machine has been used a lot with oncology patients, as well as much in the performing arts realm of things. So these are just kind of things to be cautious of. Main things are like NSAIDs or blood thinners, as you can get some bruising on more of a static pressure. Contraindications, of course, anything with an acute DVT, unregulated, CHF, things like that. Don't use it over an open wound, right? You're not trying to pull out more blood or create more of opening there. So these are just some basic techniques. So this first technique here is really, as you can see, it's a pulse setting. So the machine goes up to 250 millimeters of mercury. And you'll kind of now start to put together like negative pressure. Seems very similar to cupping. And it's pulling, right, lifting the tissues there. Traditional cupping gets much higher than 250 millimeters of mercury. So that's really where you're kind of in a safe zone here. When using it in this effusion or swelling management, you're just doing a couple pulses in around the joint and moving in a, right, distal or proximal, making sure you're opening all of the correct areas of the lymphatic system to move that lymphatic fluid out of the area. And more of a trying to, really hone in on the fascia, the connective tissue. So now I'm on a continuous setting. So you can see I have to kind of, give a little pressure to her skin to then lift up the cup itself. But it's a pretty heavy grip. I have 250 millimeters of mercury here. You can see a little redness, but it actually dissipates by the time I'm done with the next area. So some people can get those very kind of, similar bright purple cupping like, markings. That's very common for cupping, but some areas might not. So you just have to kind of play with pressure and the size of the cup. And then here, of course, this is getting a little bit more intense of you're really trying to not only stretch through the fascia, but kind of stretching through the muscle. And you can almost see some of the striations of her fascia. There is emollient on her skin so that her skin is easy to slide through and you're not getting the friction from that dermis. But kind of moving in both directions is going to be really helpful for loosening up all of the borders and surrounding areas of the muscle itself and ligaments and tendons. Right, and lastly, we're going to go into myofascial acoustic compression therapy, right? This is a newer technology and it's very common to hear shockwave, but really kind of using it in a much deeper way than superficially what we just got to with the IASTM and with the LymphaTouch. So this is really, it's extracorporeal shockwave therapy, and very commonly, like I said, in the musculoskeletal world or orthopedic world, shockwave. So it's non-invasive treatment, for acute and chronic pain. And we'll talk about the way that it works, but commonly it's to help stimulate bone healing, fascial mobilization, and tissue regeneration. Commonly, we use a piezo wave for soft tissue strains, repetitive stress injuries, trigger points, tendinopathy, myofascial dysfunction, and more of that musculotendinous area between the muscles and the tendons. So really everything is kind of overlaid on one another, and there's a lot of different tools that you can use maybe for the same similar diagnoses. So it's kind of figuring out what is going to work best for the patient. This one does feel a little bit more uncomfortable for the patient. So using this device is, might not be your first go-to, or it might be your first one, depending on the type of person or what's going on, if it's been going on for a while. The main contraindications here are really your infection, right? Tumor, clotting disorders, pregnancy just because there are really high sound waves that are kind of penetrating down into the tissues. Anything anticoagulant medication-wise, just because of the tissue vulnerability, and of course over the rib cage or over the lung tissue, right? Making sure that the path is not going straight to the lungs because that is air-filled, and we want to make sure that we keep the waves kind of away from that area and not cause further issue. So as you can see with the piezo wave, the technology is called myofascial acoustic compression therapy, or MYACT. And it's really where there are sound waves that are coming from the base of the handle here. There's crystals that beat really, really high. And instead of radial shock wave goes more outwards. With this focus shock wave, you're highlighting the pinpoint. And the cool piece about this is that depending on the size of the head here, it can determine on how deep it will go into the tissue. So you can be very superficial on the bone, or if you're going through several layers of a really muscularly developed quad, then you can choose something a little bit deeper. And you can kind of see the difference between the two there. The linear, you're just getting more of a surface area versus a very focal point. And the interesting piece about this is it's not only that you're treating with it, but it's almost diagnostic. The patient will commonly feel an ache sensation to the area. And that's really where, if the tissue is not irritated, they won't feel anything. Sometimes you have to play with the intensity, but otherwise you do, unlike ultrasounds, you do want them to feel a deep ache, and you're actually not moving it around. So commonly here, right, this is just kind of a list of research articles that are out there that have really shown good evidence for some of these things. And so I've used it on dancers coming off of a stress fracture that has been pretty stable, ostrigonome, irritations of the ossicles that way. Plantar fasciitis is a very, very common one, and it does so well with it. So once again, all the same diagnoses that we've kind of been talking about. And you'll see here, you can really change. The first side is how many pulses are going out per second. And then the right button there that I'm pushing is the intensity, and that does go up to about 18. So kind of if they can tolerate it. So I start fairly low in the ankle, and this is me treating someone for Achilles tendinopathy, right? And I'm right on that Achilles tendon. And so I'm moving very slowly until the patient says, I feel an ache there. All right, and then I'm gonna hold there for about 1,500 pulses or so until really it dissipates. And the reason why a patient feels the ache sensation there is because basically the sound waves are bouncing off of that restricted tissue, whether there's calcifications, whether there's like tissue tension down there. So really healthy tissue absorbs that sound wave and it dissipates throughout the tissue, even though it's very focal. So that's kind of the neat part, because you can kind of hit different areas as you go. Right, there are the times of backstage management, and we do get plenty of performing artists in the clinic, but I have done a lot of backstage service for many companies that have come through or shows that have come through. So you can see in my middle picture there, my pretty much my two technologies that I usually always bring with me are the LymphaTouch and the hot grips. I can't bring the piezo away with me because it's just a little large, but the LymphaTouch and the hot grips are really great because you're in this setting, you're prioritizing the treatment area. A lot of times it's getting that manual in so that you can loosen up the tissue so that they can get back on stage immediately, or taping them so that they can get through the show, and then maybe over the weekend we try to work a little bit longer on treatment. So this is really just for specifically management here. So in summary, right, every artist is unique, and how they present is going to be unique to them and their genre that they are, their occupation is in or their recreation is in. Really managing their pain because we're trying to change for the performing artist that no pain, no gain, trying to change that mentality, because that's how most, and culturally and through tradition, is how a lot of these performing artists view pain, that they, you know, I'm a dancer, I'm just supposed to dance through pain. I'm a musician, I'm supposed to be in pain. So it really is getting them to understand and doing a lot of pain education just as much as manual techniques. Right? And the rehab techniques are complex, and they're dependent on really the mechanism of action of what you need. Is it fluid control? Is it trying to break up, you know, fibrous tissue? Is it trying to promote or, you know, help with the gait theory of like getting their pain down? And then returning, right, the performing artist back to their practice and performance for not only patient satisfaction, but also maybe their job security. So it's making sure that they're able to do their occupation. And it is, and this is just my little also clinic pearl here, is when working with performing artists, they are highly skilled nonverbal communicators, and they usually, you'll see more pain through their actions or their facial grimacing. So really trying to make them feel comfortable to talk to you, because they will most likely internalize it, unless you get a very chatty performing artist who will tell you like it is and will tell you where their pain is and have no problem with communicating with you. But that's kind of just something that you think about. They're used to dancing, they're used to playing versus talking. And that's my very like condensed soft tissue management talk. I want to thank you all for listening and open up for questions.
Thank you so much, Andrea. That was really, really good. So just before we do some questions, we're going to do a quick poll. So this is just to re-engage a little bit. So we're going to get this on your screen now. So you can just see a bit of a list here. So please take a moment just to answer, do you use any of the following in clinic? So it is a multiple choice, so feel free to answer more than one. And this is just to get a nice idea of who is currently using certain modalities for treatments, and it'll lead us nicely into some questions. So we're just going to give it a few more seconds and we'll get the results coming up on the screen. All right, so just a few more people answering there. All right, and we'll get the results up now just to have a quick look. Okay, so we've got some good ones coming through. So quite a lot of you are using the IASTM, which is good. A lot of needling, acupuncture, so generally using modalities and technologies. So that's really, really good to see. So Andrea, how useful do you think it is to have a range of interventions, like we've just seen on that list, available to you as a clinician when treating performing artists?
I really think, and this is where I give a lot of kudos to my director, Ken Johnson, who really sees looking at technology as only a way to help our patients and the quality of life. And, you know, could I be treating probably just manually with my hands and using the techniques that we traditionally use? Yes, but I think it would take me a lot longer for some of these chronic patients to get them better. I have had a very large amount of patients where they've had care at other facilities and they just haven't gotten better. And, you know, they heard from their friend or colleague to come see us because they got better faster. So they're not required, but they definitely have made my practice even more rewarding because I feel that I can actually get patients better and faster. And that there's other techniques out there that can help just accentuate what I'm already doing and caring for patients.
Great. So we've got quite a few questions coming up now. So if you want to ask a question, feel free and just pop it in the question and answer section at the bottom of your screen. So we do have a few pre-submitted questions. So Andrea, how did you come about including technologies in the management of performing artists? So how did you first start using?
I first started with the hawk grips. And that was really kind of a clinic-wide initiative. We were looking to go with some sort of instrument-assisted tool, and hawk grips was a newer company to come out. So just within our area, a brand rep had dropped them off. We tried them for a week. Our patients were starting to love them. We were starting to love them. And actually the rep took them away and we didn't even know they left. And then we were all, as clinicians, saying like, we need these tools. So the hawk grips were really kind of the first initial piece on using them in the performing artist. And you know, a lot of them do holistic health as well, of going to acupuncture, right, and have been getting either gua sha or, you know, acupuncture itself or cupping. So with the performing arts realm, they're very open to using different things to help them that's not maybe medically through medication or through using, like, getting a surgical intervention. So the hawk grips were really the first thing, and then came about using the LymphaTouch. And like I said, I started using that more on post-operative patients and seeing like their swelling be completely controlled in the first week. And then the piezo wave, the shockwave is a newer thing. And that's just with, you know, talking with other dance medicine professionals there's other people that were using it with ankle surgeries or chronic ankle surgeries. And we're seeing a really good effect with scar tissue breaking up of.
So you mentioned using the hawk grips and the LymphaTouch. How would you use them in conjunction with each other, or do you tend to do that often at all, using them within the same treatment?
Yeah, so sometimes I use only one of the technologies I talked about today. Sometimes I use all three. Sometimes I'll use two. It just all depends on how much time I have with the patient. Traditionally, we have about an hour in clinic with the patient, one-on-one. So that's where if they need a lot more manual, then I will use it that way. So it just depends on how they're presenting. So sometimes I start with the hawk grips first to kind of mobilize the tissue, you know, if there is any swelling, kind of flushing the area of the swelling, getting the fluid out. If that doesn't loosen up their tissue enough as well, then I'll go in with the LymphaTouch and lift that part up. Otherwise, if I know that it's a little bit deeper or it's more of a chronic issue, I will go with the piezo wave first. But like I was saying too, the piezo wave does have a threshold of discomfort to it. The other two, you can really control the dosage and how much discomfort the patient can feel. With the piezo wave, you can too, but they do need to feel, it's just an intense, deep ache is how I describe it to them, like a very, you know, intense, deep toothache. So kind of, sometimes you use it on the first day, you can kind of really tell with the patient, like they can handle this, or they're like all for it because they've tried everything over the years. So sometimes I'll go with that and then end with the LymphaTouch to just kind of get the tissue to kind of all release out and flush out any of kind of the buildup of breaking up of the microphages and things like that.
Great, really nice. So we've got a question from D. Stringer. So with regards to hypermobility issues, what is the best way to tackle Ehlers-Danlos Syndrome?
Yes, and so that's where you'll see it's kind of a precaution for with the LymphaTouch and with the hawk grips. So EDS, right, there's many different spectrums of EDS. And so they get a lot of fascial tension because of the ligament laxity piece, right? But you also have to be really cautious with releasing that tissue too much because it's going to create them so unstable, right? And there are different spectrums where they can get more cardiovascular components there. But really for a musculoskeletal piece, I would say really go easy using some of these technologies because you do want to decrease a lot of their tension that they have, but really the important piece with EDS is making sure that you're doing motor control and stability, because otherwise you're just making them just kind of melt completely. You have to give them some support.
Right, thank you. So we've got now a question coming through. I am familiar with radial and focused shockwave, but I haven't seen the linear before. It seems like a crossover of the two technologies. So could you answer around that at all?
Yeah, so linear is just the difference. So you saw me use mainly the focused one. So with the piezo wave, you have two different sound heads that you can attach to the device. So with the focused, right, it's very, like I said, a spotlight to that area and that area only. With the linear, you can kind of get a straight down spotlight. So you're actually, it's really good for bigger muscle groups, so especially within the leg and the quad and hamstring. So it's the same idea of it being focused, but it's just going straight through into the tissue. So you're picking up more surface area to treat versus the focal piece where it's pinpointed.
And just staying around the shockwave topic, is there any good evidence that you know of for using the focused shockwave for stress fractures?
What was that last part?
So any evidence that you know of around stress fractures for the focused shockwave?
Oh, stress fractures, yes. So I think they're still doing more research on that, right? There's not really solid evidence with some of the shockwave piece, but we know that it does work. Really, it ties back to Wolff's Law, right? That, you know, making sure that it is stable, of course, in a stress fracture related, that, you know, making sure that their pain is relatively managed, and then that the stress fracture is not getting worse, so whether they're immobilized. But I've used it in plenty of times with like fifth metatarsal fractures. That's one that's very common, that actually helps with stimulating the bone growth. So I know there's more evidence coming on the horizon that is showing the benefit there. But, you know, sometimes I'm a little cautious even with fracture, right? Because we don't really know, and we know with ultrasound, right, not to ultrasound over a fracture site. So it's why can we use these sound waves there? So sometimes I am a little bit more on the cautious side just because I don't think we have strong evidence for it. It's more anecdotal and, you know, just case study based. So I think there is more and more that's coming out in the literature.
Would you say that the stress fractures is something that you commonly see generally with dancers? Is it something that you are seeing quite a lot of, or?
I see it commonly with the adolescent dancer. If I do get an adolescent dancer, say in their teens, with a stress fracture, a lot of it has to do with nutrition. So I try to get them with a dietitian to make sure, or get blood levels to come back to make sure their vitamin D is up to par, because a lot of times that is just as much as a factor as the intensity that they're dancing at versus, you know, an older dancer, especially, it's going to be more from impact and overuse, you know, and even looking at menstruation and things like that, right? That's all going to factor into the female triad of still looking at the hormone level and, you know, making sure their levels are decent there, because that's going to be a big impact to them musculoskeletally.
Yeah. Okay, great, thank you. So the next question we have here is there any real difference between cupping and the LymphaTouch system?
Is there a difference between cupping and LymphaTouch?
Yes.
Yeah, so basically they're the same sort of principles. And that's really where, right, a cupping system is a lot, you know, more inexpensive than a LymphaTouch. What I feel, I gravitate towards the LymphaTouch more, especially if it's available to me, is because I can actually control precisely how much pressure, and I don't have to worry about kind of pumping up the cup and having the cup lose suction very easily. That's kind of commonly what I feel with just a traditional cupping system versus using the LymphaTouch. And also, really, you don't have then the pulse setting where you can actually use it to help with swelling, because it is a very constant, consistent pulsing mechanism that happens with the LymphaTouch. So, I mean, if you have cups, you're technically, in the sense, using the same mechanism of action for dealing with more soft tissue to release things that way, especially if it's, you know, easier for purchase and and maybe something that you already have.
And we actually did do a webinar sort of around that topic as well last week. So yeah, if you want to check that out, it's an anonymous question there, but we can go into more detail from that webinar that we did run. So next question, which kind of technology would you recommend is applicable for patients at home? So with regards to maybe self-treatment, is that something that you get your performing artists to do at all?
Yes, and that's where a lot of performing artists are very open to what can they do for themselves. If anything, they've tried things for themselves. So that's where, like, between foam rolling, or maybe they're using, Hawk Grips makes a multi-tool that is relatively on the more inexpensive side, that if I teach my patient how to use it and they are interested in buying one for themselves to use, that's always kind of a way to go. But really with using stretching, myofascial release with a massage ball, things like that, that's really helping the carryover of what I'm doing manually to stimulate the system. And then all of those, typical techniques of, home exercise programs that we give of self-release is what then I have the patient do to the same areas to keep that tissue from getting tight again. Because that's very common of, they go right back into class and rehearsal, you're using all those same muscles. Sometimes you're in this stuck pattern of things just staying tight, and having to really kind of get things to unstick, especially if they're not supposed to be overly working like they are.
So just on that as well, how often do you manage to see performing artists patients? Is it more difficult to access them because of rehearsals and practices? Is something you have to do is explain to them about going away and self-treating a little bit more? How does it generally work with yourself?
Yeah, so a lot of it depends on whether, they're in a performing arts high school, they're in a collegiate conservatory, or they are professional. So typically I see patients either once to twice a week, just depending on the severity of their impairments. Twice a week is probably a little bit more common initially in the beginning, and then we'll taper off to one time a week. I typically see patients kind of later in the day. So our clinic stays open until 7 p.m. And that's really where, we get them either after rehearsal or after school. But we are on the conservatory campus, we have, more kind of midday time of maybe where they don't have classes scheduled. Or it's just working around them. Like we will go, we will make it work however it needs to in order to get a patient in.
Great.
The backstage management too is the nice piece of kind of triaging them eventually into care, or if they're traveling through, then like I'll coordinate with the next city that they're going to, and we keep documentation to help that therapist then know what's next.
Okay, great. So we've got a question here. Do you add some active movements into your treatments? So this attendee here has just explained that they deal with football players who are generally tight. So they're assuming that it's must be very different dealing with flexible dancers. So yeah, a little bit different. So it'd be good to know if there's anything that they can add to treatments to increase flexibility and strength.
Yeah, so right, very different, right? Stiff, tight tissues versus very flexible, tight tissues, but still have the tightness piece. So with all of the techniques, you pretty much can use it in an active range of motion way. So if you're trying to get more shoulder flexion, and they're tight in their subscap region, or in their thoracic, you can put the LymphaTouch there in a continuous stretch, pulling very, caudally as they reach up towards into flexion, so you can create more of that dynamic piece. So I do find the LymphaTouch is really good for working, especially in the intersections of where muscles of those compartments match. So like, for example, around your IT bands, of really actually working the vastus lateralis and then working more of the lateral hamstring to free up your IT band, right? Versus just kind of stripping along on that IT band and expecting it to loosen up, because it's not going to. So I find, especially with very kind of dense, hard, very muscular tissue, they do really well with the hawk grips, the IASTM, and LymphaTouch. And that's where maybe you try to use the hawk grips at first, and if you feel the tissue's a little bit more pliable, great. Then maybe, you know, facilitate with them foam rolling or more dynamic stretching, static stretching at the end. Otherwise, using the LymphaTouch on a very constant high pressure to really loosen up the multiple layers underneath the skin will really help loosen up the connective tissue so the muscles can then stretch better. So that's really where I find a major difference. And I have treated more of collegiate football players before, and yeah, getting them to stretch that way versus like if you make them do yoga, they're gonna be like, no. So it's just kind of seeing what works best for each athlete.
Great, thank you. And we've just got time for one more question. So if you haven't managed to come around to answering your question, because there has been quite a lot coming through, we will answer them either just typing back or we'll get in touch with you after the webinar. So this is quite a nice question to finish on, Andrea. So what treatment do you like to use the most? And you can't say all of them.
That's not fair. My favorite, I mean, can I pick a favorite of the day that I've used? We'll pick a favorite of the day. I guess the LymphaTouch, in the sense of I can really do two different things with it. Like I feel like it's the most diverse and dynamic to being able to use for, you know, like stretching and really decreasing muscle tension, but also controlling swelling at the same time. But like my hawk grips are my close second or first.
Good answer. All right, we're going to finish the questions there. So thank you so much, Andrea, for answering those. And thank you guys for joining us this evening and for your participation. We hope you've enjoyed it. So following this, you will receive a survey along with the link to the webinar recording. We'd really appreciate any feedback and suggestions on further webinars. Andrea, oh, you've already done it. I was going to ask you to click along, but there we go. On the slide there, we've got some upcoming webinars that you can check out on our website and that you can register to. The ones on that slide there, they are invite-only sessions that we're putting on in the next couple of weeks. So these are available for being able to provide you with some more information on how to implement certain technologies. So anything that Andrea's mentioned this evening, or anything that you might be interested in finding out more on, those sessions are going to be a closed group session that will be able to answer any questions at all. So we can also put those in the chat section as well. Otherwise, you can email us on info@physequip.com. But apart from that, I think we're all ready to end there. So thank you again, Andrea, for joining us. It's been really great, and thank you everyone else, and have a good evening.
Thank you for having me.
Thank you.